everyone to a Zoom and Learn on a Wednesday, which is not normal for us, but we really felt this information was important for you to have. So we have partnered today with Relaro Medical Trials and want to introduce them to you and just kind of give you a little background on what we're talking about. So Relaro Medical Trials, they are going to be talking about the onset, the progression, and the behavioral changes that are associated with Alzheimer's disease and different dementias. They're also going to talk about available treatments that they have that they offer through Relaro Medical Trials, hence the name. And one of the things that I think is most important, talk about the types of doctors that can identify, diagnose, and treat dementia, because it's definitely not something you want to go to your primary care physician for. So they're going to help you identify what that is. So I'm going to start by introducing our two doctors with us. We have Dr. Seema Gupta. She is board certified by the American Board of Psychiatry and Neurology. She attended Texas A&M University, where she graduated summa cum laude. She later attended Texas A&M Health Science Center College of Medicine for her doctorate in medicine. Dr. Gupta began working in research in 2019 and has been one of the primary researchers on the Alzheimer's dementia with agitation study at Relaro Medical Trials. She's interested in understanding more about how and why patients develop brain disorders that lead to memory and cognition problems. When the pandemic is over, and that is key, she is most excited to travel. I think we're all in that boat and see all of the friends and family she has been missing. Definitely travel is on my bucket list. We also have joining us today, Dr. Alicia Howater. I knew I was going to do it. Okay. Dr. Alicia Howater, and she is a PhD. She completed her training in clinical psychology at the University of Missouri in 2014, and she joined Relaro Medical Trials in 2016. She is currently the manager of clinical operations. Alicia oversees the care of every patient in the clinic at Relaro Medical Trials. As part of the team, Alicia performs some of the assessments used in the diagnosis of Alzheimer's dementia, as well as other cognitive tests and research studies. She's been conducting assessments of memory and intelligence since 2009 and finds the work with Alzheimer's patients to be especially rewarding. When she's not at work, she can be found chasing her 2-year-old daughter, who I'm sure keeps you extremely busy, or watching professional sports. So love to welcome Dr. Gupta and Dr. Howater to us here today. The floor is yours.
Thank you. Thank you. Well, thank you for having us today. We're so excited to be able to talk more about Alzheimer's and dementia and some of the things that are sometimes confused with those disorders, and then some of the risk factors, a little bit about the disease, and then hopefully some time to answer questions that you guys may have. Okay, ready? Okay, so as much as everyone thinks that technology is only a problem for them, it's also a problem for us. So please be patient with us if you're not able to see our screen, please let us know. Can everybody see our screen here?
Yes, we can see it.
Great. Okay, so you guys already heard a little bit about us. So thank you for attending our presentation today. So usually what brings people in to talk about Alzheimer's? Usually it's because they say, I've just been having some trouble remembering things. And they might say, well, you know, I've tried leaving myself notes. I've tried, you know, my husband or my wife keeps reminding me, or my friend told me I forget something. And at some point they start to get a little worried about the things they're not remembering. Okay, so to start off, we want to talk about some of the different things that can look like dementia or look like Alzheimer's, but really are something different. Okay, so the first one we call delirium. So delirium is when you have a really short-term event that causes you to have trouble with your, what we call consciousness. So that's things like your memory, your focus, your attention. So I'm sure all of you guys know someone who's had maybe a really bad fever, they've been dehydrated, sometimes a UTI, or your thyroid level being off, and that causes us to be very worried that we might have something like dementia or something that's really serious. The good thing is that delirium is usually something that we can treat with, medication or, hydration or things like that. So that's our really short-term one. Believe it or not, the next most common thing that affects your memory are things like depression and anxiety. So for us, no matter what age you are, if you're 99 and you come in and you say you've been having trouble with your memory, the first things that we're going to look at are depression and anxiety, because those two things really do interfere with your memory and your ability to kind of pay attention, to attend to information. In fact, people with high levels of anxiety just through like a stressful situation, we're really likely to do things like misplace our car keys, forget where we, forget to lock our door, stuff that we do, every day, 10 times a day, we suddenly start forgetting. Or maybe even it's something even more significant. You forgot today was Sunday and that you were supposed to go to church today, or you forgot that today was Wednesday and you had that Zoom and Learn you signed up for. So usually we look at if you're going through a stressful life event, or maybe if you're going through a period of grief or some other life situation that may be contributing to what's going on mentally. So if you also have a friend or a family member that comes to you and says, oh, I'm really worried that I may have developed dementia, I would first look at those areas of their life before jumping to the conclusion that it's dementia. Okay. So then the third category is dementia, and that is where we really see that really severe or significant memory loss and just decline in what we call cognitive function. So just want to step back for a second and talk about that word cognitive. That's a big fancy word. Cognitive just means anything related to thinking. Okay, so I think everyone can relate to this because everyone has had this happen, right? You just can't seem to get your thoughts straight. You walk into a room and you go, what the heck was I doing in here, right? You go somewhere and you say, I know I had a reason to come here. What was I supposed to do? Or you have a friend call you and 3 or 4 days later, they call you again and say, hey, I called you. And you go, I totally forgot you called me, right? So anything related to your thinking is when we talk about cognitive functioning, okay? All right, so when we talk about dementia, I like to think about dementia as a tree, okay? Dementia is a tree that there are a lot of different disorders that fall under dementia. But what dementia is a big group of symptoms that affect your thinking, your social abilities, and they interfere with your daily functioning, all right? The type of dementia that you have depends on where in the brain you have something being affected. So we have our brain here, right? This is our extra brain. We can all borrow it sometimes. So your brain has, the outside of your brain, and you have the inside of your brain, and you have all these different areas. And depending on where in your brain you are having problems, that's going to affect the type of dysfunction that you have. So Alzheimer's disease is a very specific type of dementia, and it is the most common form of dementia in adults. So that's usually the one that we think of first. When somebody's having memory problems, we say it could be Alzheimer's, right? It's the first one that we go to because it's just the most common one. Okay, so again, dementia is that overarching diagnosis, but there's actually 170 different types of dementia, even more than that now. We have Lewy body dementia, we have frontotemporal, we have vascular dementia, we have Huntington's disease. We could probably go down the list. There's no way I could name all of them, but we could probably get a pretty good list if we try. So Alzheimer's is just the most common type. So we think about it as kind of a branch on the tree of dementias. There's lots of different ones. Okay, so Alzheimer's disease was first described by a German physician, Alois Alzheimer. So does anybody out there speak German? So you can probably correct me on my pronunciation there because I probably don't pronounce Alois Alzheimer quite the way it should be pronounced. But That's where the name comes from, is the doctor who really discovered it. So this doctor actually had a patient who had this really persistent memory loss. She started having hallucinations. And so then he started observing other people with the same symptoms and eventually kind of came up with this disorder. Alzheimer's is not a normal part of the aging process, as Dr. Gupta is going to talk about. It's really not that many people that have it, but here's what happens. When people have pretty severe Alzheimer's, we tend to put them into like assisted living centers, right? They need to go someplace where they can have assistance. So when we go visit someone at an assisted living facility or a nursing home, a great majority of those patients do have Alzheimer's disease or dementia. So then we start to think, oh my gosh, everyone who gets older gets dementia, or everyone who gets older gets Alzheimer's. But as we're going to talk about, it's really not as common as we tend to think they are. Okay, so Alzheimer's is not just the normal part of the aging process. Okay.
All right, so I'm going to talk about some things that may predispose a person to developing Alzheimer's. There are a wide variety of risk factors, as you can see. The big one is age. And basically, as you age and progress in life, your risk starts to increase. But that really doesn't start until age 65. And even at that time, the actual probability of you developing Alzheimer's is pretty low. From about age 65 to 69, your risk is at about 2%. It doubles then to 4% between the ages of 70 and 74. Then it doubles to 8% between the ages of 75 and 79. Then it doubles again to 16% once you get to age 80 until about 85. And over 85, your risk increases to 35%. So it's really not until you're much older, 85 and above, that your risk goes up significantly. Another important risk factor is gender. In general, females are more likely to develop Alzheimer's than males. Not to say that males don't get it as well, it's just the risk is higher in females. Race is another important risk factor. African Americans have the highest risk race-wise of developing Alzheimer's. And then there's genetics. Specifically, there's a specific gene called apolipoprotein E4, which is basically a risk gene for developing Alzheimer's, but doesn't necessarily determine that you will. So basically, it's been found in a lot of individuals with Alzheimer's, but just because you have that gene doesn't necessarily mean 100% that you are going to develop Alzheimer's. It just increases your risk. Another important risk factor is parental history. Having a first-degree relative with dementia actually gives you a 3 to 4 times greater risk of developing Alzheimer's dementia later in life. And then there are a lot of environmental risk factors as well. Stress and inflammation plays a big role, which is true just in general about a lot of medical conditions, that inflammation is an underlying cause of multiple medical conditions. And then basically any medical condition that ultimately can lead to poor brain perfusion, since Alzheimer's is a disorder of the brain. So things like midlife hypertension or high blood pressure, midlife high cholesterol, obesity, diabetes, sleep apnea, or other sleep disturbances. And then it's also been found that healthcare neglect, basically low levels of mental, physical, social activity, all of those things can increase the risk for Alzheimer's. And so that's why it's really important, in order to mitigate your risks, to be as physically active as you can, engage in exercise, keep your brain active, engage in social activity with others, and follow a healthy diet. Those are kind of things you can do to combat the development of the condition. And then going along with that, lack of education and mental stimulation is another risk factor. And that may be just because people who use their brains more tend to compensate better when these problems do arise. But that's why it's also really important to just keep your brain engaged and active as much as you can. All right, so what exactly causes Alzheimer's dementia? So there are two specific proteins in the brain called beta and tau, which are kind of defining hallmarks of Alzheimer's dementia. They're basically these abnormal accumulations of protein that affect the functioning of the neurons in your brain and the connections that they have with each other, and that kind of results in a progressive loss of brain function over time. So those two proteins are called beta and tau. The beta are what eventually form these amyloid plaques, and then there's tau, which accumulate to form neurofibrillary tangles. And I know that might seem a little bit confusing, so we're going to show you a video that kind of breaks that down and explains that a little bit better.
Okay, so now I get to share my screen again. Okay, can you guys see our screen again? Thank you.
In healthy people, all sensations, movements, thoughts, memories, and feelings are the result of signals that pass through billions of nerve cells or neurons in the brain. Neurons constantly communicate with each other through electrical charges that travel down axons, causing the release of chemicals across tiny gaps to neighboring neurons. Other cells in the brain, such as astrocytes and microglia, clear away debris and help keep neurons healthy. In a person with Alzheimer's disease, the most basic form of dementia, toxic changes in the brain destroy this healthy balance. These changes may occur years, even decades, before the first signs of dementia. Researchers believe that this process involves two proteins called beta amyloid and tau, which somehow become toxic to the brain. It appears that abnormal tau accumulates, eventually forming tangles inside neurons. And beta amyloid clumps into plaques, which slowly build up between neurons. As the level of amyloid reaches a tipping point, there is a rapid spread of tau throughout the brain. But tau and beta amyloid may not be the only factors involved in Alzheimer's. Other changes that affect the brain may also play a role over time. The vascular system may fail to deliver sufficient blood and nutrients to the brain. The brain may lack the glucose needed to power its activity. Chronic inflammation sets in as microglial cells fail to clear away debris, and astrocytes react to distressed microglia. Eventually, neurons lose their ability to communicate. As neurons die, the brain shrinks, beginning in the hippocampus, a part of the brain important to learning and memory. People may begin to experience memory loss, impaired decision-making, and language problems. As more neurons die throughout the brain, a person with Alzheimer's gradually loses the ability to think, remember, make decisions, and function independently.
Okay.
And this is just kind of reiterating what that video showed in a kind of simplistic view. The normal brain with the purple neurons and the brain with Alzheimer's, where those neurons have these accumulations of neurofibrillary tangles, and then in between the neurons you have these amyloid plaques, which all kind of combine to cause damage to the brain.
Okay. So how do we diagnose Alzheimer's? Well, some of you guys may already know this, but the only way to truly diagnose Alzheimer's is with an autopsy, because we have to look at all of those brain tissue parts, right? So we talked about how in your brain you might have shrinking of the brain, you might have damage to your hippocampus. So we can only truly diagnose Alzheimer's after death, okay? But that doesn't really help us while you're alive, right? So what do? Well, what we usually do are a combination of things. So we call this a multidisciplinary approach. So that's where you're usually going to have doctors like Dr. Gupta, who are going to do kind of those neurological side of tests, your brain scan. They're going to look at things like urine and blood and your hearing and your visual exams. And we're also going to do what we call neuropsychological testing. Those are the kind of things where we're going to ask you questions, maybe play small games with you and try and measure things like your response time, how well you can answer questions about, the present moment versus the past. And we're going to put all of that together to come up with what is a good assessment of your ability. So like Dr. Gupta said, some people are actively using their brains every day. They're actively involved in social groups like these ones. And so you guys might have better scores in general than someone who sits at home all day and just watches television or doesn't really get out. So the more you're doing to keep your brain stimulated, the more we're doing to kind of push off those losses, okay? So we're gonna be testing things like your memory, your language, your motor skills. We call visual spatial ability. So I'll just tell you guys, I am terrible at these and I don't have dementia, right? So this is things like looking at where a piece of a puzzle fits in, or looking at a map and figuring out direction or where to turn. Terrible at that stuff, right? Terrible. Okay, we also do these things called executive functioning. So if we think of what is an executive, right? It's a boss, right? Someone who works in a corporation. So executive functioning means things like your decision-making ability. So if you think about a big executive that works at a desk and all the things they have to do, right? Where they might have to do logistics and planning and decision-making. That's what executive functioning means, okay? Finally, we're gonna look at things just like your personality changes. So a lot of times we'll have caregivers come in, a couple come in, usually, a spouse, two spouses, or it may be, a parent and a child, or it may be, cousins or good friends. But one of the things they say is, well, they're still able to keep up with conversation, but they're so agitated all the time, or, everything just makes them fly off the handle. So we're going to look at personality changes too, because that's going to give us a sense of where things are in terms of the diagnosis. Okay, so once we have determined that a person has some form of dementia, we have really 4 stages that we work through. The very first stage is called mild cognitive impairment. And something to note is that there's no timeline for these, as far as you can only have mild cognitive impairment for 6 months, or you can only have early Alzheimer's for 2 years, right? So people may have mild cognitive impairment for a decade or longer. People may have early or mild Alzheimer's for a decade or longer. People may have moderate Alzheimer's for a decade or longer. Usually though, once we get to late or severe Alzheimer's, we do see a more quick progression. Okay, so that very first one, mild cognitive impairment, is usually where you're only seeing problems with memory, right? So kind of those things of, I can't seem to remember the schedule, or I forgot my doctor's appointment. And there can be frustration obviously associated with that. That's where I misplaced my car keys again, or I forgot to do the task that I always do. Every night it's my job to take out the trash and I just keep forgetting. Or your spouse may say, I reminded you 4 times to do this and you just keep not doing it. So those are what we're talking about, mild cognitive impairment. All of your other capacities are still intact. Your language is still good. Personality is still largely intact. Visual spatial skills are intact, and there's no real disability. It's more frustration that goes with that memory loss, right? Okay. When we start getting into earlier mild Alzheimer's, this is where we start to see more judgment problems and more kind of interference with activities of daily living. So because of that mild memory loss that's getting a little bit more severe, this is where someone may have more trouble driving because, for example, they might get in the car, start driving somewhere, and then forget where they're going or forget where they are. Or they might be driving home and then they make a wrong turn and they don't have the ability to kind of reason out How is it that I get back to where I was going, which obviously can be dangerous. They may have a hard time managing money. So when they go to pay a bill, they may pay a bill twice, or they may forget to pay a bill altogether. And they may even just have trouble kind of balancing out the cost, or balancing a checkbook, or how much of something should cost versus how much they're paying for it. We start to see more mood and personality changes. We also see increased anxiety. That makes total sense. If you're aware that you're having more confusion, and you're aware that you're making, choices that are, affecting your finances or things like that, that's definitely going to lead to just a natural form of anxiety. So we start to see people just kind of lose that sense of spontaneity, because they start to worry about leaving their house. They start to worry, like, I don't think I should go to the grocery store anymore, or things need a lot more planning. Before, the things they used to do just on a morning, I'm going to go up and go get donuts this morning. They say, no, I'm not going to do that, because what if I get lost, right? So we start to see some more of those mood and personality changes in these early stages of Alzheimer's dementia.
And the next stage, in terms of increasing severity, is what we call middle or moderate Alzheimer's dementia, which is basically just kind of a further deterioration of different cognitive functions, as well as just overall functioning. Patients will have increasing memory loss and confusion. Usually with Alzheimer's, the first thing that's affected is short-term memory, but kind of as it progresses, long-term memory can also be affected as well. In general, you'll also see a decreased attention span, and problems with reading, writing, working with numbers, that type of thing, as well as difficulty with just thinking in general and organizing one's thoughts. Another thing that is a lot of times evident in middle or moderate Alzheimer's dementia is inability to learn new things, or kind of cope with unexpected situations, which can lead to a lot of frustration. And then that kind of goes along with the next point of increase in agitation and anxiety or tearfulness. Additionally, another thing you kind of see at this stage is wandering. Basically, patients will wander around in their homes, or even outside, or wherever, just because they're kind of confused and don't really know where they are. And these symptoms tend to worsen later in the afternoon and at nighttime, after the sun goes down, which is where the term sundowning came from, which is kind of pretty specific to patients with dementia.
So, and one thing that's important to remember, if you know someone, if you take care of someone or have someone in your life that has dementia, these problems that you see here, these are not intentional. It's often very frustrating as a caregiver to say, gosh, I've told you 10 times where we're going today, or you've already asked me that 10 times, or gosh, why do you keep trying to escape the house? That's dangerous, right? So that can be really hard for caregivers to not feel frustrated. So if you can know that these things, they're not intentional, this is just their brain's response to what's going on in the brain, that it's not that this person doesn't, that they want to be wandering around late, or that they want to be difficult. This is just kind of the natural progression of the disease.
And basically, as the disease continues to progress further, you may see some of these symptoms, which include different problems with motor skills, such as problems getting out of a chair or setting the table, things like that. You'll also can sometimes see, with the increased agitation, one of the things a lot of patients will do is repeat the same thing over and over again. They'll also sometimes yell out, become increasingly irritable. When things progress even further, they can sometimes start having hallucinations, where they either see things that aren't there, or hear things that aren't really there, or delusions or suspiciousness, basically thinking that people are out to get them, things like that, that kind of aren't really based in reality. But yeah, stealing from them, definitely, that's a big one.
It's a common one. People think that someone stole their items, especially when they've misplaced them around the house. Then they may accuse a partner or someone else who's been in the house, grandkids or children, so-and-so stole my item, so-and-so stole my And it may even be so-and-so stole my shoes. Well, why would someone steal your shoes? But, they can't find them and they start to develop that paranoia. So that's kind of where their brain fills in the gaps.
And then a lot of that then kind of can result in them trying to hide things because they think people are trying to steal from them. Another big thing with this stage is loss of impulse control. Basically, they become kind of disinhibited and start behaving in ways that they wouldn't ordinarily behave. Whether this is shown as, speaking in a vulgar way or undressing at inappropriate times, or just basically not behaving in their usual ways because they're more disinhibited.
So towards the end of the disease, when we see people who have the very severe dementia, that's where really the ability to access different parts of the brain is really limited. So this is why it may be hard for people to recognize family members or loved ones, even people they've spent, every day with for the last 40 or 50 years. So it's obviously, spouses or children, they may not recognize their faces. They may have an inability to communicate. So you may notice a lot of mumbling or humming or just, not responding to conversation or questions. We see like weight loss because for many people, they have lost appetite. They don't have that kind of biological urge to eat or to drink. And then obviously towards the very end, we start seeing things like skin infections, seizures, difficulty swallowing, loss of bladder control, things of that nature. But again, that's towards the end of the disease, the very severe side. So it's important to remember that, some people live, 15, 20 years and remain very mild, while other people may decline more rapidly. Unfortunately, there's not a good way to predict, which way a person will go, although Dr. Gupta brought up a lot of the common factors that we might look at. So a person who's, always been pretty healthy, has engaged in lots of exercise and does a lot of things to stay, mentally stimulated. We predict a little bit better of a course and hopefully a much longer term before we get to some of these more severe outcomes.
All right. So there are certain medical treatments that are available to help with some of the symptoms of Alzheimer's. But unfortunately, no medication has really been shown to reverse basically the process of degeneration that's occurring in the brain. What some of these medications can do is maybe slightly improve symptoms and slow the progression a little bit. But they don't really have necessarily a very robust effect. The medications that we have on the market right now are kind of targeted at delaying cognitive and functional loss, as well as improving behavioral symptoms. There's one large class of medications, which are called cholinesterase inhibitors. And basically, those act by increasing levels of a neurotransmitter in the brain called acetylcholine, because part of the hypothesis of what happens in Alzheimer's is that these neurons that produce acetylcholine degenerate. So these medications kind of help combat some of that. There's also another class of medications which act a little bit differently, but really is kind of all trying to achieve the same effect. Basically, with all of these medications, it's kind of something that you need to discuss with your physician and kind of do a risk-benefit analysis, because all medications do have risk factors in general. Some of them may have more benefit than others, and so is really kind of needs a decision with your physician to decide if that's something that's appropriate or something that could be helpful. One thing to note is basically once dementia has gotten to the late stage or severe stage, these medications really aren't going to do much. They really are used more at the mild to moderate stages to have the most benefit possible. And one thing also to note is that if someone is on these medications and stops them and then later decides to restart them, they may or may not decline once they're off the medications, but will definitely not be able to gain the prior functional level that they were at, even with restarting the medications.
So maybe best to continue on a medication if you feel like you're getting some benefit from it.
Correct.
Okay. So that kind of seems like a bummer, right? That's always where we get to the point where we go, gosh, that doesn't sound like very good news at all, right? So there are things you can do, right? Staying physically active, staying socially active, challenging your brain every day. And then, of course, the reason that Dr. Gupta and I are here is because we are researchers and we are looking for what else can be done to slow the losses that people experience or to give people a better quality of life once they have been diagnosed with something like dementia. So we currently are working on a research study for a drug that is on the market. It's called brexpiprazole, and it is hypothesized to make agitation less intense, to make agitation episodes shorter, and to make sure that agitation happens less frequently, right? So why does that matter? Well, it can give you a much better quality of life, right? It can also give the people around you much better quality of life, and we can kind of smile about that, right? But when a patient is agitated, it's not just the patient who is bothered, it is the person who's living with that person, it's the family around that person. It's all the people that interact with that individual that can, either be a calming presence or can say, gosh, I just can't even be around my dad anymore because he's just so agitated all the time, right? So really, this is a drug that we're hoping might give people a much better quality of life while dealing with symptoms associated with dementia. So if we go back to some of those symptoms that we associated with the middle or moderate stages, Dr. Gupta, what would this medication potentially help with on here?
So basically this medication is targeting kind of the behavioral symptoms. So definitely with the restlessness, agitation, anxiety, the wandering is something that it also targets as well. What else on this list?
So sometimes agitation can interfere with your attention. So if you are less agitated, you may be able to sustain attention longer to do things like problem solving, reading, working with numbers. So if you're a person who really enjoys doing things like crossword puzzles or word circles or things like that, but you find that agitation kind of amps you up and you just can't do the things that you enjoy doing, this may give you an opportunity to do something that you did enjoy doing before. And the same thing like with, sometimes people with more agitation, they get reluctant to go to church, they get reluctant to go to dinner, they get reluctant to do, things with friends because, your partner might say, oh, I can't bring you out anymore because you just have, you start swearing, you start having that foul language. So this can help with some of those things that we see too.
And same thing on this slide. A lot of those repetitive statements, people repeating themselves, that happens with Alzheimer's, that is kind of related to the agitation and is something that can be helped with this medication as well. The yelling out, as well as the loss of impulse control.
It may help with some of that paranoia and
even
suspiciousness.
That, I was going to say that as well.
So if you guys happen to know someone who you think might be interested in participating in a research study, they don't have to be diagnosed with Alzheimer's or dementia, but they do have to be experiencing some of those symptoms. We would love to talk with you further. You can send those individuals our direction. So I have a phone number with an extension and an email address. And we're also would love to take some questions. If anyone has some questions for us today about questions that came up during our presentation, we'd love to talk to you more.
All right, guys, so I am going to add myself here. We got a lot of questions that came through, so I'm going to read those off and go through, which is wonderful. And also, as always, you want to just follow up with Relaro Medical Trials information can be found in the magazine and on our website, and their information is also listed there at the bottom of my screen if you are interested. All right, let's start with some of these questions. Look, I said I wasn't going to do it, and I said all right. Goodness gracious. Okay, so the first question that we had come in is why does dementia affect some people faster and others slower before it actually has a severe effect is what the question was.
Well, part of it, or I guess the big thing of it, is everyone basically has different cognitive reserve and cognitive resilience versus cognitive vulnerability. And so just because each person is different in terms of that effect, that can then result in their, I guess, how they, their level of decline and how much worse they get compared to another person. Also, in general, a lot of times dementia is something that kind of presents differently in different people. And so, like I said, some of that is because of the differences in cognitive reserve versus vulnerabilities, and some of it is just other things.
There's always a piece that's just luck, right? There's, just fate. And then, like we said, we do look at risk factors. So again, does a person have an active lifestyle? Do they have hypertension? Do they have high blood pressure? Do they have high cholesterol? Do they have diabetes? Are they overweight? Have they done the things to try and do the preventative side before the disease actually started progressing?
Right.
Because I think, unfortunately, every year we all learn that prevention is easier than cure, right?
Yes, isn't that the truth? We definitely learned that lesson this past year, I think.
Oh, gosh, yeah. Keep learning it over and over.
All right, so you might know what they're asking for this question, but I don't. And if we need to get clarification, we definitely can. But they asked, what about taking, and it has EDTA? Does that sound familiar?
EDTA?
Yeah. Hey, David, if you want to take yourself off mute. Yeah, I don't know. Okay, we're going to move on to the next question. I'm excited for this one.
Not unfortunately.
Okay. I'm excited to say this one, if you have neurocardiogenic syncope, is it a precursor to Alzheimer's or dementia?
I'm not sure if it's an actual precursor, but in general, anything that has, like I was saying earlier, that decreases perfusion to the brain in any way can put you at increased risk. But I'm not sure if it's an actual precursor.
Well, part of it's associated with decrease in blood pressure. So that would actually be protective.
Interesting.
That's a good question.
That is, and it's an interesting way to look at it because you both make perfect sense. It's like, do they cancel out each other then?
Right.
One reason could be higher, one reason could make it lower. So, all right. Well, so, hey, whoever answered that question, I personally think that's great news. Okay. So we had someone ask, in my family, the men get dementia around the age of 50. Sometimes it affects the women, but not very often. Do you have any idea what kind of dementia this may be? And they also made the comment that it didn't affect their father until he was 80 years old.
Well, I do know that the early onset dementias, which sounds like maybe what's going on there, are a little bit different in terms of, I guess, compared to regular Alzheimer's dementia. There's kind of like a subset, I guess, of a type that is specifically genetic and gets passed down that causes that early onset. And then sometimes the way that genetics works, or sometimes there's something that's called incomplete penetrance, where basically when it gets passed down, sometimes it's not to the same degree. And so that may be why the father didn't develop it until later. But the kind of the pathophysiology and stuff behind that particular early onset type of dementia is a little bit different.
Yeah. Could it
would-
possibly be a vascular dementia?
That's, I mean,
That
that's
was my
possible
thought
as
too.
well. That's
Yeah.
also possible.
So my thoughts were, did the men in your family drink more than the women? Did the men in your family smoke more than the women? Did the men in your family have higher stress careers or lifestyles? So I would be thinking about those risk factors.
Yes
as
to all
well.
of it.
So
Yes to all of it.
All of it.
Okay.
Yes to
So
all of it. There you go.
that would be, you know, from I'm not that kind of doctor, right?
Right.
That was a great answer, by the way.
Yes.
But my
No,
first
that
thought
makes
would
sense
be,
as well,
are they
definitely.
drinking more, smoking more, exercising less, stressed more? That would be my
Yeah.
thought.
And a lot of times you can have, like, you know, kind of like a mixed presentation where you have vascular dementia and Alzheimer's, and, you know, and a bunch of different things at
Yeah.
play as well.
Okay. Okay, so this is an interesting question, and I've heard different takes on this, and I'm curious to hear what your take is. So what actually causes the death of Alzheimer's patients is what the question is.
Typically, it comes from infections. So typically people with Alzheimer's, you know, in late stages, they have reduced hunger and thirst. So they're not giving their body things like calories and hydration. So they develop things like urinary tract infections or pneumonia because they're sitting, you know, they're sitting long periods of the day, leaning back. And so they're having that fluid build up in their lungs. And then their body doesn't have the, you know, the reserves to fight the infection the way that, you know, a normal healthy adult would.
Wonderful. Okay. 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 What effects does cognitive improvement drugs that are advertised like Prevagen do?
So from what studies show, those really haven't been found to be very effective.
Okay.
I guess if a person wants to take them, if they're not causing harm, be my guest. But as far as what the studies show, those really haven't been proven to have much benefit.
Okay.
And I guess I would have that same caution for things like people that ginkgo biloba is like one of the, I'm always, you know, our patients are constantly saying, well, you know, my daughter said if I start taking the shark cartilage and the ginkgo biloba, and, you know, there are some people that feel a great deal better taking those medications, but the research behind them is not as strong as we would like to see. But I think I agree with Dr. Gupta. If you start taking it and you notice a difference and it's not causing you side effects and your provider says this is safe for you to continue, then by all means. But I hate for people to put all their hopes into something that really doesn't have a lot of research behind it.
Right. Most certainly. This might be something best to refer them to their own physicians. Maybe you tell me, but we had someone ask if you could provide a list of the different categories of medications, of medication and medications within those groups, and then followed that up with, do the medications conflict across the categories?
So in terms of the medications between like glutamate receptors
Is
versus,
that the question?
if that's a question.
So basically there's two different classes of medications. One is the cholinesterase inhibitors that I mentioned. There are 4 medications that are under that category. Aricept or donepezil is one of them. Cognex or Tacrin, which is a generic name, is the second one. Another one is Exelon, which is a brand name, or rivastigmine, which is a generic name. And that one is also available in a patch form as well as oral. And then the last one is galantamine. And all of those basically have the same mechanism of action. Then there's a separate class of medications that are called glutamate receptors that act a little bit differently. They basically inhibit the overstimulation of receptors in your brain by glutamate, which can cause something called excitotoxicity. There's only one class of medications, or one medication in that class, and that is, the brand name is Namenda. The generic name for that is memantine. So like I said, that one works a little bit differently than the other class. There is also now a combination medication, which is the Namenda from this class combined with Aricept from the other class, that is often prescribed. And I think those two are the only ones that are approved for the more not quite severe, but more moderate. The other ones are from mild to moderate as well. But I think the Aricept Namenda combination is also approved for moderate to severe. I don't know if that answers the question or not.
I saw a lot of those, of that combination when I worked in memory care assisted living. So yes. Okay. So basically then is as far as the medications conflicting across the categories, then, you know, your Aricept and your Namenda, they work well together.
Yeah.
Now, is it recommended to do Namenda with one of the other drugs that you talked about that were similar to Aricept?
I mean, there's no reason you couldn't.
Okay.
I think it's just that there is an actual combination drug approved that are the formulation that already has both of those combined in it.
Perfect. All right. Okay. What about loss of hearing? Is that associated with Alzheimer's dementia?
So if you think about your brain, right, your brain processes every bit of sensory information. So what you hear, what you see, what you taste, you touch, and you smell, right? So when you have Alzheimer's, you have a hard time communicating between the different parts of the brain. So, right, if I get my brain back up. So if I have a tangled plaque here or here, if I hear something, but the back of my brain is what needs to interpret that hearing sound, or the front part of my brain, then yeah, I could actually have a hard time interpreting that stimuli. So if you have hearing decline, that should not be a, oh my gosh, now I have dementia. But people who have dementia have sensory loss across the board. So they have difficulties with taste, with touch, with smell, with hearing, and with vision.
Wonderful.
And another thing in general is if someone just has hearing loss for other reasons, a lot of times that can sometimes mimic some of the symptoms of dementia. If you can't hear,
you seem like you're not paying attention.
Right.
You know, people tell you something, but you didn't quite hear it. So then you seem like you forgot it, even though you didn't really forget it. You didn't hear it to begin with. So.
Yeah, that's always an important one. That's what I always used to tell everybody. First and foremost, get your hearing checked. It's very important, very important. Okay. Are low tolerance and frustration and extreme defensiveness, could those be considered symptoms?
Yeah, that would fall in kind of those moderate categories. And again, that's where I would look at, are you going through just a really stressful life event? Do you have some grief going on? Are you in, a change in life that is stressing you out that's kind of causing you to be grumpy? Right. Or is this getting pretty persistent? Because that's definitely the agitation stuff that we see.
Right. This is a great time. I'm going to interject real quick and ask my own question. So for, the person asking that question, or if you know someone like that and you're going, you really should go talk to somebody, go see a physician. What type of physician should they seek out? Can they come see you? If they're having, honestly, those seem prime examples of great candidates for your trial that you're doing for behaviors. But if they wanted, where would they go to? Can they go to you? Can you help them diagnose in addition to the medical trial, or do they need to go to see a different type of doctor?
Sure. So we can absolutely diagnose here as part of what we do. But the first step would be calling and talking to one of us and going through kind of a whole symptom questionnaire. So if that's the only symptom that you're seeing, then that's probably not going to be, dementia. Like I said, it's probably going to be more of a stressful life event. But if it's something that we start to look at that whole package, then yes, we can do that thorough diagnosis here, as long as it would be, pertaining to the study. If you did not want to start with a research trial for any reason, you can always start with your primary care doctor. Primary care doctors, that's, their first thing is they get a little training and everything, so they can help identify it, and then they can make a referral. If you have, the type of insurance that allows you to see any provider that you want to see, I would probably consult with a neurologist.
Definitely.
Yeah, a neurologist would be my first go-to. But again, that kind of depends on, healthcare has so many factors like insurance and availability and things like that. So
Right.
we're definitely a resource. If you want to call and speak with us, we can talk about the symptoms that you're experiencing or that your loved one is experiencing, and help you with a referral of that direction too.
Fantastic. All right. Okay, I mean, we got lots of questions, so settle in. And if we need to cut it off, we can always get these
Right.
questions to you later, or they can call. This is
Dr. Gupta.
always a hot topic, but is dementia connected in any way with Parkinson's?
Yes.
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 There is a type of dementia that Parkinson's patients can get.
Mhm.
Lewy body dementia is the big one that's associated with Parkinson's. And so a lot of times in the later stages of Parkinson's, patients can develop
Mhm.
that, but that is different than Alzheimer's.
Right, right. Yes. Okay, actually, what type of physician should be visited if symptoms suggest dementia? There we go. We answered that. Who's the best doctor to consult for assessment? We
Dr.
answered
Gupta.
that. There you go, Dr. Gupta. All right. Okay, this is a great question that I like, especially since we have so many ladies with us today. Is what is the reason as to why women seem to be affected more than men? Do we know or understand that?
I can give you my answer to that. Do you have
Okay.
a patient? You have a
Yes,
patient.
I
So
actually
Dr.
have a
Gupta's going to
patient
run
to
and see a
get to.
patient.
Okay.
She
Okay.
she's able to, and we're still here. She can join us. But if we think about the risk factors, right? So one of them is a lack of education. So we know that women historically have had less access to education. So a lot of times, women completed, high school, and after that, we didn't have as much access to college or, secondary education. So
Right.
that's one part, right?
Okay.
Stress. Women have the stress of raising kids, and, we have to help that, wear all the hats and do all the roles. So there's definitely that. Things like estrogen plays a role in things like where do we store the fat on our bodies? Women, especially in middle life, we tend to kind of get that apple shape that's not as healthy. So there's stress and inflammation. So a lot of those risk factors, we see those more on the female side than on the male side. So it makes
Okay.
sense that women, are more predisposed to getting things like Alzheimer's, dementia, because we just have so many more risk factors.
Right.
The other reason is we live longer statistically, right? So we know that, you got to keep in mind your risk of having Alzheimer's dementia is only about 2% in your 60s. In your 70s, it's between 4 and 8%. That's still not that many. That means 95 people out of 100 are not going to have it, right?
Right.
But once we get over the age of 85, that's where we start to see, over 30% of people now are at risk. Well, we know that women tend to live longer. So if we're living into our 90s and, we become centenarians, then we have a higher risk of developing cognitive disorders.
Okay. That makes a lot of sense. Okay. Average lifespan after being diagnosed.
So I know that the research from a few years ago was that once you hit the moderate phase of Alzheimer's, we had about a 15-year life expectancy. But again,
Wow.
there are some people that can linger in that middle stage for over a decade. Now, once you get to the later stages, it's typically, you have a shorter lifespan at that point.
Right. Okay. I always saw people in the later stages, so your response actually really surprised me. Okay. How many folks are in your study?
In our office, we have had just a handful of patients. So it's a study that's going across the nation, and I think they've even opened up some sites in Europe recently.
Oh, wow.
So I think the goal is to get, have to look at my paperwork. I want to say that they're looking for, 500 to 600 people to participate across all sites. So we definitely have room for more.
Fantastic. Okay. Um, so someone stated that their mother had dementia, and what can they do to protect themselves from getting it? And they're also concerned too because of the pandemic that obviously has altered our lives so much and reduced their social interaction. That's what we have Zooms for. But what things could someone be doing if they're concerned?
Well, I love seeing this Zoom and Learn today. I love all of the, the interaction that you guys are doing. I love that when you guys were coming in, everybody knew each other. I think that's fantastic. We have to get creative, right?
Mhm.
So it's a pandemic and we have to get super creative in ways to keep our social interactions up. Really with your brain, it's just like every other muscle. It is use it or lose it. So the more that we just allow ourselves to sit back and I'll just watch Wheel of Fortune tonight. You should be interacting with that as much as you can. Interact with everything that you can. Brain puzzles, brain teasers, conversations. I'm going to say the E word, the dirty word that nobody likes to hear, exercise. That's one of the things that we know can almost reverse problems that we have in the brain to a degree is, aerobic activity. So getting up, getting active, not isolating ourselves. Now, I'm not telling you guys to go and put yourselves at risk. We're in a pandemic, so please be safe. But phone calls, letter writing to your friends. I have recently started writing letters with my husband's grandmother. I don't have any living grandparents, but how fun is that? We actually get to go to our mailbox and open something. It's like the funnest thing to get mail from each other. So things that you can do to stimulate your brain and your body are preventative. Eating healthy, avoiding excessive alcohol, all the things that your grandma always told you was good for you to do. She was right. We should all do them, exercise, eat right, take care of ourselves.
Yeah. Well, and along the lines of the exercise, some of you may not know, we do have a Zoom low impact aerobic exercise class we do once a week on Tuesdays. So there you go. You want to get moving, it's half an hour and we have fun. So
no reason not to.
Yep. Okay. So we already talked about prevalent. Did we talk? Yeah, we talked about prevalent. Okay. Yes, this presentation will be archived so you can view it later. We'll post it on our YouTube channel at Celebration Magazine Live. So once it gets cut down, we talked about what kind of doctor is best for diagnosis. Okay, this is a great question. Can cancer treatments or medications accelerate dementia symptoms?
Yes, so just like we know cancer medications can accelerate bone deterioration and muscle deterioration, they can also influence cognitive deterioration. And it's hard to predict which people are going to be most impacted by that. I definitely would never deter someone from getting cancer treatment or a treatment that's life-saving, but yes, that can impact, later mental functioning.
Okay. Okay. Peggy, I will make sure that these questions are included in the video, so do not worry. Parkinson's, is it hereditary?
Gosh, that's a much better question for Dr. Gupta, because I want to say yes, but there's also, I want to say it's like diabetes, and that yes, there is heredity risk factors. So if you have a parent or a grandparent that had Parkinson's, you are more likely to develop it.
Mhm.
But just because you didn't have a parent or grandparent that had it does not mean you cannot get it.
Right, right, exactly. Okay. Judy Brewster said it was a great presentation. Thank you. Pat Stephen asked about contact info for you guys. So their website is listed on my screen there. It's relaromedical.com. And their phone number 469-730-3282. Lewy bodies is the type of dementia that Robin Williams had. So there you go. Lynn and Bob said, so informative. Thank you so much. Vivian and Dennis said, thanks for all the information. Great presentation. That is the end of my questions. We have reached the end. So if you guys would love to take yourselves off mute, of course, let's give a round of applause, both for Dr. Howater and Dr. Gupta, even though she's not here. It was a fantastic presentation. And I know they would love to hear from you. So thank you so much for joining us. We really appreciate it.
We have really enjoyed our time and look forward to talking with you guys more about any questions you have or any other information. We're happy to be a resource.
Yep, and make sure you check the magazine, because I know, and if you get our newsletters, make sure you look at our newsletters, because I know we've posted some articles and things in there also from them that you can look at. But I know we'll be including much more information in the future from them, so that'll be wonderful. All right, well, thank you so much, Dr. Howater. Make sure you thank Dr. Gupta for us.
I will.
Totally appreciate you sharing your knowledge today. Everyone else, don't forget tomorrow we're going to be doing our interview with Dr. Stone here in Dallas. So we're going to be sitting with him and talking about his medical memoirs. And then next week is February already. Oh my gosh. So next week we've got Essentially Spoiled on Tuesday. We're playing bingo on Wednesday because Wednesday is for bingo. And Thursday we have our Hobos and Hoovervilles presentation with someone from the FDR Presidential Library. So thank you once again for joining us. Have a wonderful rest of your day.
Thank you.